looks on. All right. Cool. So a new way to pay for healthcare. Ladies and gentlemen, my name is Edwin Lubanga, CTO and co-founder of Snark Health. Today I'm presenting to you an advanced alternative payment model. Actually, let me be bold a bit. You'll be able to see a doctor at $0 in the coming, days. Sorry. Can you help me move there? Perfect. All right. So the current payment model are not working both for doctors and patients. And just to give you a bit of context, in Kenya right now, about 17% have access to some form of health insurance. NHIF, that's about maybe 15, and then private insurance, 2.7. So leaving majority of Kenyans, and also most parts of the world, paying out of pocket. And we know that's very expensive. So this is leading to patients going broke and dying prematurely. And the current models, just to give you a quick overview, there are three. We have fee-for-service, where you walk into a clinic, whether you have insurance or you don't have insurance, and you still have to pay, the patient's expenses are always high. Then we have capitated payments. Maybe some of you are part of these programs, where you have a fixed rate that you're paying to access healthcare. And here we are seeing again, the patient expenses high and doctor's income decreasing. And then we also have a bundled payments model as well, which again, when we look at the expenditure here, it's still high. So what Snark Health is doing is we're building a platform that's connecting patients and doctors with a narrow network for diagnosis and treatments. And we're approaching it in 4 ways. At-risk contracting, that's step 1, meaning the Snark Health or doctor can go at risk for that consultation fee that you normally pay for your favorite telemedicine apps, which is still part of our solution, but that's just a feature to us because telemedicine is really not solving the cost problem, it's just shifting risk and utilization. That means you don't have money to pay the consultation fee, so Snark and doctor will go at risk. And they'll go at risk in the sense that when we sell your data that you've consented in, when you monetize on the data, you won't get anything, but the majority of the earnings will go to either the doctor or Snark Health. That's at-risk contracting. Then we have data monetization. Again, patients and doctors, for the first time, they are earning from the healthcare data that they're generating themselves every day. You see a doctor, you're always generating data. And that also, of course, the data is de-identified. We're following all the compliance rules and ensuring that your data is not leaked, your privacy is at hand, if you choose to be part of the monetization. And that money goes back to your wallet. And then we have the health savings vehicle, which we're calling the Hippocratic coin, that is tied to the healthcare data that's growing over time. So this data, this coin, you'll be able to convert to your local fiat and pay for healthcare expenses as needed. And then lastly, we have the liquidity providers. This is, we are discussing with other lending platforms. They can come and lend money for patients and doctors on our platform at a lower interest. So this way, we are seeing overall the expenses will continue going lower and doctors' income increasing, and utilization will be optimal. So we make money on transaction fees. We have the 9% on the doctor consultation, and we are the cheapest in the sense of telemedicine. And then our narrow networks that are participating in our network, we negotiate discounts on behalf of patients. And then our second revenue channel, which is the data monetization, if all the 3 players participate in it, doctors, patients, and Snark Health, that means 33% will go to the patients if the patient is the payer, 10% to the doctor, and then 90% will go to Snark if the Snark is the one taking the cost. And then we have the Hippocratic coin, which is our reserve asset, and then finally the DeFi, where we have lending and staking. So our customers are retail. That means we have doctors and patients. These are our key customer segments. And data customers, on the other hand, we're talking of pharmaceuticals, medical device, and so on. Total addressable market, it's a 20 billion global opportunity. And now we're just targeting in Kenya alone, that's about 70 to 80 million USD. Henk is the CEO, is my co-founder. I met him 24 years ago. He's a doctor, 17 years. I'm leading the tech. Nicholas is here. He's also is helping us with operations and Showmeet advising on fundraising. So today I'm asking for a couple of things. Partnership, If you're interested in lowering cost for accessing healthcare, you want some exclusive data sets, you want to access maybe a health savings vehicle or a digital health initiative you want to work with us, I would like to talk. And we are raising 450K for an 18 months runway. And the other side of the slide is the traction, which we've built in the last, just 9 months. We've onboarded over 4,000 patients. We're working with 300 doctors, clinic officers, and also these combined specialized doctors as well. And also we have a USSD that we launched during COVID that helped also county hospitals to understand why a patient is not coming to the hospital. So we use for information and also just, to understand what's going on from different households in the villages. And our app has over 4,000 signups, combined that's doctor and patient. Thank you.
Edwin, great presentation. I love the future that you're dreaming of, and we need more people like you out there. I guess one question, the first question I have is, very few businesses have succeeded in monetizing data, whereas in Africa, in Kenya. So I'm curious a little bit about who is buying the data that you're producing and at what price and sort of, the regularity. Can you take us through that a little bit?
Yes. So I will start from actually also including the pricing side, which is still a discovery process. The data customers, we've grouped them from pharmaceuticals. For now, we are discussing with one distributor who is very keen to understand the movement of medicine, because eventually our algorithm kicks out and shows, okay, we've had a lot of requests on malaria, this type of malaria tablets that have been prescribed by doctors. So these analytics, it's easy for them to compete out there with the other guys. And then government, funny enough, we did something in Western Kenya for the government. They wanted to know how come patients are not coming to our hospital. Are they self-diagnosing themselves? What's going on? So we used that insight for them, but in the future when they come to talk, of course they'll pay for it. And then in terms of the unit economics of the data, that's still a discovery process because different data customers have different unique issues. Even telecom companies can still tap in, non-healthcare data is still existing in our platform. They might want to know, the type of Androids that are using our apps, and that insight we're still selling to them. So the analytics, you can look at it from different angles. Yeah.
Thank you.
Thanks.
Just from my side, so with healthcare, it often is quite a difficult business to move across borders because legislation, different way the ecosystem works. So are you building something here that has the potential to move internationally, not only throughout obviously the East Africa region, but then we start looking different parts of Africa and then into developed markets as well?
Yes. So first of all, the regulatory framework is different from different countries. And the good news is in Kenya, of course, we are following everything to the latter. But if we have to move to Uganda, we have to check again. What is the screening process? How do they onboard doctors? How do they confirm the KYC and all those steps? So yes, we're in discussion to try to attempt in Morocco and in Nigeria. So we'll be in Morocco for, I don't know if you guys are coming. There's something called GTEx Africa. We'll be in attendance. So, and that has already given us some guys to start talking to. But what's more important is if we understand the regulatory framework for each, sometimes regulation doesn't block you. In fact, you need to embrace it so that then you understand slowly. Because, for example, here in Kenya, Data Protection Act was just enacted recently. So there's still a learning process for everyone in the ecosystem. Yeah.
Okay. Yeah, and I think you will just, as you get there, the data often is going to stay in country, and there's a whole bunch of different costs that come in with a rollout into new countries, particularly with medical information. So a country would then say you have to have your data in Morocco. I'm not speaking on Morocco's behalf, but that does happen a lot.
Yeah, I see the hurdles. Yeah. So that can be, but what we've already tried with the just proof of concept, simple survey and stuff. At least the African governments are not too strict. South Korea was crazy. They just said, no, just not now. So.
Okay.
Yes.
Your mic's not working.
My mic is off. My mic is now on. So what
the four
exactly?
different revenue streams. Yes.
What exactly is your main revenue streams? What are you focusing on at the moment?
Yes.
And then I think you said something about a hippo coin. a coin.
Hippocratic coin, yes. Funny name.
Yes,
Yeah,
what is that? How
Hippocratic,
does it
yeah.
work?
Yeah, so four revenue streams. Right now, we are the first one that is active. You pull out the app, and anyone in the room, please sign up. You'll get, there's some gift you'll get there in your wallet. That is for consultation, which we are taking 9% on every doctor appointment, and then revenue share when we. We take you to one of our participating clinics, so that means you don't need to break your bank just trying to get well. So that's already happening. Now the second model, which is data monetization, right now we're only doing analytics for one data customer who is paying us some money every month. But we are hoping in 6 months we should be able now, because we've churned some data since 2019. So we have something enough to start saying, okay, this can be sold, yeah. And then the Hippocratic coin, again, if you sign up, we haven't turned on the coin yet, because I hope there's a liquidity provider in the room to buy some coins. Once it's turned on, those coins, you can convert to now your local fiat, yeah. But that again, it's tied to, can we find any liquidity provider soon? Yeah.
Cool. Thank you.
Keep the mic for a second. Out of the countries that you are in, you talked about South Korea there. Have you considered the United States? We have a slight problem with also extending healthcare services to people there.
The problem with South Korea, okay, so this is what we went with the thesis that we are trying to save. We'll guarantee the government at least 5 to 10% savings on every money they, on each citizen. But then now, when we kicked in with the idea of the data monetization, then it stopped.
Okay.
So we were trying to do a savings model for the government, because interestingly, South Korea, in terms of insurance, at least majority are sorted.
Yeah. But as I mentioned, the US is not now.
30 million Americans don't have insurance.
Yep. All right. Thank you for that again, Edwin. Sorry.